start with you move to left coronary. You can see the lesion is same as the before the cine. And you decided to put a direct stent, microporter direct stent in the diagonals, and the length probably is 25. Then I decided to put 29, 2.5, 29 millimeters direct stent. Go. This is direct stent. It's very easy, and this is the result. I think I don't pass to OCT because you have to control the quantity of the contrast. Okay. Then now I saw the result. I think it's okay. You decided to pass OCT in the circumflex. Next. Then because the lesion is so occluded, then I try to post-dilatate with a balloon with 2.0, and before pre-dilatation you run the OCT. Then the image of OCT you can see. Andre, you comment this.
So if you could just change for OCT for this one. Yeah, you can see it, Alex and Ron.
Yeah. So this is post-dilatation.
So here we have the run. It's just one run for this lesion on the CERT. Okay, you see a small branch.
Section there.
No, this is balloon effect.
You're gonna see
it looks like a noodle there.
Very tight lesion.
Okay, you saw because
okay, if you could just put in the bookmark, you can see a 1.7, 1.8 MLA in the CERT.
And the length is 23. 32.
32.
Then you decided to put a stent 2.5 to 33 millimeters. It's now I will put the stent.
We are live now, Alex.
You're going to put a DS, so which DS are you using?
I think what are you seeing?
If you could just put the angel, please.
Ask the panel a little bit here, Mark.
You can see
why
you
deploy the
cross the
stent.
lesion very easy.
So Mauricio, for instance, in your service, I mean, here is a little bit of a different situation. Mark will be able to do, perhaps we deploy 5, 6 drug-eluting stents. In your practice, despite the fact that the patient is not very happy with surgery, in a multivessel disease patient like that, would you insist? Hold on, Marco, we're just discussing here a little bit.
We can't hear you.
Yes, Alex, because the patient refused surgery.
She's
a 75-year-old lady with multiple disease, but some long lesions, but some of them are quite focal lesions. If the case is quite complex, we should be aware of the amount of contrast for this lady.
Alex, tell me something because I can't hear you.
I
don't know if you're hearing us, but we lost the audio.
You lost the audio, but
coming to the end. But I would like to ask, because for me it seemed to be that the posterior descending artery was occluded with the slow flow, and we have a very tight lesion in the LAD as well. So all the ventricular septum and the anterior wall is quite jeopardized here. I would start the left coronary artery with the LAD.
So you would not send to surgery. Let's say this is a real-world patient. You don't have DS in the public scenario here. But would you still insist in bare metal stent? Right now, this is number 4. Probably it's going to be 5 or 6 stents. Would you feel, Cesar, in a public institution, you would insist in surgery? Because you can tell, talk to the family, you know. There is this situation, wrist stenosis is X, stent thrombosis is Y. I think this is a good candidate for surgery. What do you do?
surely I would consider surgery for this case if I don't have DES to use there. I guess too many stents, very long stents, and the rate of restenosis here is, I guess, beyond 50%. So I would consider surgery if I not have.
And with plenty of DES, you would go ahead and...
I guess, and I agree with Mauricio. I will start from the LAD.
From the LAD.
And then go on.
You agree, Julio?
I think it's the main concern
Alex,
is when
now I
you
can
use
hear
a
you.
lot of stents, the stent thrombosis.
Quantum
I
trace.
think it's a big problem. And it's a long lesion. And as you said before, I think it's better to begin to fix the multivessel disease in LAD first. I tried to get it first to solve this problem.
The LAD is a TIMI2 flow. Certainly, that's a very high-grade stenosis. It's going to come to the LAD, it's a TIMI2 flow. So I think it would have been prudent to start with the LAD anyway.
So Alex, to your question, if you really don't have the resources, one of the things that you can take the courage approach. So you treat the most lesion that you think it's the culprit with a stent, and the rest you just go with optimal medical therapy. You know that that's probably going to work in terms of mortality and MI. Should be sufficient. If you need to convert, you convert, but you can pick only if you know, like which one here. I don't think it was the right, so you leave the right untreated. So, I mean, it's not untreated, medical treated.
Would you do that guided by FFR, or you just perhaps...
I think if you would have done FFR, probably would have been negative. I mean, it would be more than 0.80. That's my feeling, but, you know, I cannot tell. But I think that if you have to choose between doing long bare metal stents versus medical therapy, sometimes you should consider medical therapy because you're not going to have restenosis.
Even with DES. And the patient...
No, with DES, if you have the efforts to DES, you should go with DES. But if you don't have it and you have to say long bare metal stents, which is almost guaranteed restenosis, then maybe optimal medical therapy. If this is not the culprit lesion for angina, then you leave it. We're not here to treat every wrinkle in the vessel.
So what are you doing now, Marco? Can you hear?
Yes, Lex.
Okay.
I was post-dilated with 3 because the inner, the distal part is 2.4 and the proximal part is 3. Then I put a stent to 2.5, 33 millimeters, and I was post-dilated with 3.0, 10. And now...
A non-compliant balloon.
It's now compliant. And now I will do the OCT to show you.
Which stent did you use here? Which DES?
It's the microport.
Or the microport.
Firebird.
Yeah. So it does have a
Microport.
It's also a
biodegradable.
Firebird.
Yeah, Firebird.
Durable polymer with
Durable polymer.
sirolimus. So I think there is a factoid there. And you know, it's hard to see from here.
Okay,
Let's see.
I just, yeah.
We are preparing for the OCT run.
And the injection, I see the power injector actually connected, so probably
I
using
think
the
the
power.
recommendation is
Yes.
power injection.
Yeah, because your image was crisp and clear, which is suggested you do.
Let me see what the audience has to say about this case, because it's it's syntax score 31 and 5-6 stents. Put the lights up a little bit. Raise your hands. Raise your hands if you would send this patient to surgery. In two situations. I think first with bare metal stent, there will be probably a consensus that most will consider surgery. But
DS
with
versus-
DS versus surgery in this case. Syntax 31 and a 75-year-old lady. We have to, of course, see if she's high risk for bleeding, because in a patient like that, I would give, clopidogrel and aspirin for perhaps more than 12 months. Raise your hands. Who would do DS, if DS is not a problem? DS.
I think that's the majority.
It's going to be a little bit more.
Prepara a bomba pra gente. Tem contraste lá?
Do you remember that the patient refused the...
Latest registry is multi-vessel disease with Resolute, Zymes. I mean, they look pretty good. They're not so bad.
Eu acho que saiu da câmera, isso, né? Hã? Não é?
The guiding is pushed back a little.
Retificado.
The OCT.
Cara, talvez ela vai encascalhar.
Anybody here with
Eu vou fazer o
experience with
OCT agora.
Firebird? Use Firebird? Firebird Microport?
Yeah, it's Firebird 2.
Yeah. We have
Fourth
So
Firebird.
you see the blood is not fully washed out, that's why you see so much oil.
We helped with registry in Brazil, and then
No,
TLR is
pera.
extremely low, Ron.
Yeah.
You know, it's perhaps a better cipher
Yeah.
with a better platform. So
It's not the same polymer,
let's
right?
do it again,
Oh, it's the
please.
same polymer as cipher.
It's durable polymer, but performed in a much high-tech way
Pronto.
because it's
Então, vou fazer
thinner, more
o
biocompatible.
OCT agora.
And they have a bioabsorbable polymer version as well.
Vai.
So that OCT image was not so helpful. I don't know why. Is that because it was obstructing
tá um pouco
distally
fora,
and it
talvez
was
não
not
fique
washed
bom.
all the way? But the run is very quick, so we have to see it frame by frame. That will be the solution.
O catéter
Ângelo.
estava meio...
Eu acho que essa corda aqui já foi, o cateter estava fora da corda.
Tá.
Vai.
You have to combine, you mean? You know, that's another approach that you have to consider. I mean, if you have those big RCA, very focal stenosis, if you want
Dá outra
to treat
corda.
with, for cost reasons, with 3540, with bare metal stent, theoretically, of course, it wouldn't be so harmful. Although I have to say, if there is no financial restraints, why not go with the DS?
This was an abstract I presented at the ACC 8 years ago in the early days of drug-eluting stents when we actually had the cipher to the LAD and bare metal stents, the hybrid procedure, and follow these patients up for a period of 2 years.
We published a paper like that at the American Heart Journal.
Combination. Tell us.
Hybrid approach, and actually it did work very well. If you do
worked
it
very
smart,
Yes.
you can make it working. David Cohen did the cost analysis. He actually showed that it's not cost effective to stent with DS all the vessels.
Correct.
So you have to be, if you go for the short, large vessels with the BMS, you can save a lot of money.
There's
And you
no-
do this hybrid approach.
There was no difference in follow-up of the both groups at 1 year's time.
Yeah, I
These
think
were-
this is
This was a
feasible.
cohort of nearly 700 patients.
Yeah, what we did everyone cipher versus selected based on the physician
Okay.
decision. And it was the same outcome.
Same outcome.
If
That's
you do it
interesting.
smart, I mean,
Yeah.
obviously, if you have a diabetic, long lesion, small vessel, you're going to put it drug-eluting stent. But if you have on the same patient a very focal lesion, you don't have to do it. Like this case in the right, you could have picked only a short
I
stent.
have to change my mind for that.
Sumiu, o cateter
Because
está
generally
ok?
when I use one stent, I
ficou
want
fora
to use
da-
the same for all the vessels. Even when I choose a DS, I
vapor.
try to choose the same for all the vessels. But as a rationale, it makes sense.
Yes.
Empurrar na
You're
corda.
going to show us the post-stent OCT images?
Yeah, you're just
Marco, can